All right, let's get into it. The blitz starts now. Hypertrophic cardiomyopathy. This isn't just a disease, it's a genetic war, and it's being fought inside the heart muscle itself.
The inheritance pattern? Autosomal dominant. That means all it takes is a single copy of one mutated gene to set off the cascade. And where does this mutation strike? Right at the heart's engine room, the sarcomere.
The main culprits, the genes you have to know, are MYH7 and MYBPC3. These are the blueprints for essential sarcomere proteins. When they're defective, the muscle growth goes haywire, it gets disorganized, and that interventricular septum, it gets abnormally, dangerously thick.
And that thickened septum, it creates a blockage, a physical obstruction in the left ventricular outflow tract, the LVOT. Now here's the absolute key. This obstruction is dynamic. It's not fixed. It changes depending on how much blood is in the heart. And that leads us to the classic clinical finding.
The paradoxical murmur. It's a systolic crescendo-decrescendo beast that completely flips the script. It gets louder with a Valsalva maneuver and softer when the patient squats. This is the exact opposite of almost every other murmur you will ever hear.
And the stakes couldn't be higher. This condition, tragically, is the #1 cause of sudden cardiac death in young athletes. So understanding the genetics, mastering these exam maneuvers, it's not just academic. It is absolutely critical to preventing that devastating outcome.
Okay, before we go any deeper, we hit the safety gate, our mandatory international medical disclaimer. This content is for educational purposes only. It is not medical advice. For any clinical decisions, you must consult official guidelines and a specialist physician.
All right, Sarah, let's really dive into the core concept here. HOCM, or hypertrophic cardiomyopathy, is a favorite for board exams for a very specific reason. It seems to completely break the standard preload rules that we apply to almost every other heart murmur.
So let's put it to you. Why on earth does this murmur get louder when we decrease the preload by having a patient do a Valsalva maneuver? It feels totally counterintuitive. Oh, it's all about the physical space inside that ventricle, Dr. Collins. It's such a cool mechanism. So in HOCM, you've got that huge asymmetric septum creating a really narrow exit. When you have a patient bear down, do a Valsalva, you're decreasing venous return. Less blood comes back to the heart, so the ventricle itself actually gets smaller. This physically brings the septum and the mitral valve closer together, which makes the obstruction even worse. And boom, the murmur gets way louder. Then when the patient squats, you get this big surge of venous return. All that extra blood fills up the ventricle, stretching it open. That literally pulls the septum and the valve apart, opening up the outflow tract and making the murmur much, much softer. It's all about that dynamic space. Brilliantly explained, that is the key distinction everyone needs to remember. It's a dynamic obstruction, which is totally different from the fixed obstruction you'd see in something like aortic stenosis. Okay, so let's shift gears from diagnosis to management. The latest guidelines put a massive emphasis on risk stratification for sudden cardiac death, or SCD. So how do we figure out which of these patients needs an implantable cardioverter defibrillator, an ICD? Right, so while the official guidelines have a detailed risk calculator, there are some major red flags that should immediately get your attention. First, any family history of sudden cardiac death is huge. Second, has the patient had any unexplained fainting spells or syncope? Third, on imaging, is the maximum wall thickness 30 millimeters or more? And fourth, are we seeing any runs of non-sustained VSAC on their monitoring? Any one of these seriously cranks up the patient's risk, and it means an ICD is basically mandatory to protect them from a fatal arrhythmia. Exactly. And that 30 millimeter number, that is a critical hard cutoff you have to remember. This, of course, brings us right back to where we started, the genetics. Yeah, because this all stems from that genetic mutation. And because it's autosomal dominant, family screening isn't just a good idea, it's a must. The recommendation is clear. You have to screen all first-degree relatives of an affected individual. If you find this in your patient, you have to evaluate their parents, their siblings, and their children. It's that important.
So what's the treatment pathway look like then, Dr. Collins? Are we still starting with beta blockers?
Absolutely. They are still first-line therapy, no question. By slowing the heart rate, you increase the time the heart has to fill during diastole, which helps reduce that obstruction. But the real game changer in the new guidelines is a drug called mavacamten. It's a cardiac myosin inhibitor, which means it directly targets the root cause, that hypercontractility of the sarcomere. And, for patients who still have symptoms despite medication, we can escalate to invasive procedures like a surgical septal myectomy or an alcohol septal ablation.
Which brings us to our question of the day. For all of you out there in your clinical rotations or in practice,
Have you actually had a chance to examine a patient with suspected HOCM? And if you did the Valsalva maneuver make the murmur change as dramatically as the textbooks say it does? Let us know in the comments below. We'd love to hear about your real-world experience. Okay, Sarah, let's lock in the HOCM rules for good. Time for the memory chant. Ready. Septum is thick. Preload is plaque. Less blood, more sound. More blood, less sound. SCD is the threat. Rules are locked. Less blood means more sound. More blood means less sound. Perfect. So we've just mastered the hypertrophied heart, the one with the thickened wall. But what happens when you have the exact opposite problem? What happens when the heart muscle is too thin, too weak, too stretched out? To find out, make sure you subscribe and join us for our next masterclass, where we'll dive into dilated cardiomyopathy, the balloon heart. See you then.